Sir, we are live now, sir. Good evening, everyone.
Where is it? I have lost the video somewhere.
No, sir, we can see you and we can listen you as well.
You can see? Okay, good, good,
sir.
good.
Everything is.
I think there is a beautiful girl's photo I see in front of me.
Everything
good.
is working.
Good. So good evening, friends. Today it's a historic day, I would put it. I think this is the wisdom of our president, Dr. Rajesh Mishra, who actually thought of putting in the toxicology at the top of our agenda this year. And toxicology, we have had almost how many members? I think 29 members we have had. And 29 members have been meeting every week on the Tuesday at this time. And we have been able to put in a lot of things in place. And even the cases also have been entered all across the country, but not very many. And then we thought that we must really go on the air and virtually we must meet everybody here so as to make it popular and do a good job at the end of the year. The whole idea is to have a toxicology kind of case studies all across the country. We will keep a record of all that is going on, including the number of cases, the type of cases, the kind of management we have, and the results, of course. And at the end of the year, we hope to put something in the process and we can carry it forward. I hope that we will continue to do that job all throughout from now on. And this is an attempt to make it popular amongst all the intensivists to join us, I think, for a very, very noble cause and to live up to the expectations of our president and the executive committee of the ISCCM. And I'm sure this is going to be a resounding success at the end. And I don't see the end. I think it's going to be a continuous process. So today we have the first webinar, which is on snake bite. And this is on poisoning. And we will then next, I suppose, we'll go on to organophosphorus poisoning. And we will cover some of those very common and sometimes, I think, later on uncommon as well. Poisonings as we go on, right? So today we have the snake bite, and snake bite. India, of course, is one of the worst countries affected. I would say Southeast Asia, Africa, Brazil, and I think some of these South Asian countries, and India is perhaps the worst country to be affected by snake bites. Snake bites, actually speaking, we should not be losing any patients, but is it a fact? No. I think we lose a lot of patients because of the snake bite, particularly in the rural areas. And there are many causes for this. So today we listen to Dr. Senthil Kumar and a galaxy of panelists who are very, very reputed amongst us. And they will be discussing for about an hour on the snake bite various nuances. With this, I hand over the proceedings to Dr. Prashant Kumar, who is a spearhead, so to speak, in this particular process. He has been doing tremendous work day and night. I'm sure it is night as well, Prashant. And he will be now taking over to conduct the business. Thank you, Prashant, and it's all yours.
Thank you so much, sir. Good evening, all ladies and gentlemen. And we welcome you to the first of its kind webinar on snake bite, because it is the first of the series which will be coming up from the National Toxicology division which is working with the ISCCM. So Indian Society of Critical Care Medicine has started conducting a national toxicology survey, and we request you all to come forward and participate in this national survey. Share the data of toxicology and bring out the national data bank, and you can participate through the link on ISCCM website. This is how it will look like when you go in, and this is how this starts with your first introduction and the basic details. So today for this webinar, you already heard Dr. Banambar Ray. He's head of the department, Critical Care Medicine, Some Ultimate Medicare, Bhubaneswar. We have amongst the panelists Dr. Dhruv Chaudhary, past president, Indian Society of Critical Care Medicine, head of the Department of Pulmonary Critical Care Medicine at University of Health Sciences, Rohtak. He has many credentials to his credit. We have Dr. Dilip Punde with us, who's consultant physician, and he's the person who has treated more than 7,500 snake bite cases and not stopping with it, and not so cosmopolitan city. Then we have amongst us Dr. N. Gatpati. He is the director, Dhanvantri Institute of Medical Education and Research, Erode. Sir is also doing very noble work in that area where he is treating snake bite patients and saving lots of life there. We have Dr. Punya TKS, who is Professor, Tamil Nadu, and Dr. MGR Medical University, Chennai. And to moderate the session, we have Dr. S. Senthil Kumaran, who is the Medical Director, Manian Medical Center, Erode. So with this, I hand over to Dr. Senthil to take us through the opinions and the visions of our panelists. Dr. Senthil.
Thank you very much. At the outset, I'd like to thank Dr. Venkata sir for giving this wonderful opportunity, and my friend Prashant Kumar, who has been behind this webinar. And with this introduction, I am going to share a case. Are you able to see the screen, sir?
Yes, please go ahead.
Yes.
So the webinar will be presenting first a case and followed by the discussion with the experts. Okay. So this is a 35-year-old male, was brought to the emergency room with a history of accidental snake bite. His right arm was tightly tied with a rope. So you can see this was a picture when the patient presented to the emergency room. He had a tight tourniquet and patient had a snake bite. So in emergency room, he was conscious, well-oriented, afebrile, dehydrated. 2 fangs marks were clearly visible at the dorsum of the right forearm. On a close look, you can see the fang marks. He was hemodynamically stable and maintaining adequate saturation. Low-grade fever was there. So meanwhile, we sent the investigation. Investigation turned to be a little higher on creatine, and bicarbonate was normal. Other electrolytes were normal, and INR was 1.1, and the 20 minutes whole blood time plotted at 18 minutes. So we had a diagnosis. The snake was not brought in. So the working diagnosis in the emergency room was snake bite. Probably could be a neurotoxic, or it may be a dry bite. So in emergency room, the tourniquet was removed under the observation. Immediately after removal, and we started an initial dose of 10 vials of ASV because he was complaining of difficulty in breathing. Subsequently, he developed ptosis and worsening of difficulty in breathing just 2 hours immediately after ASV. So another 10 vials of ASV was given. You can see the patient is having a ptosis. And he was also having a broken neck sign. So in ICU, he was intubated and electively ventilated. After 72 hours, he was weaned off from the ventilator and extubated. There was no ptosis or shortness of breath. So here I am stopping the presentation. And I'm having a few questions which will be discussed with the panelists. So will it be a neurotoxic, or we can call it whether it is a dry bite or a false snake bite? So the question to Dhruv sir.
Yes, please. Good evening.
Good evening, sir.
You
Sir,
see, yes, please.
sir, this patient had initially having a normal 20-minute whole blood time. PT-INR is also normal. He didn't have any complaints till the tourniquet was there. So can we say whether it is a dry bite or a false snake bite?
You see, good evening, Dr. Senthil and the whole team of ISCCM for initiating and discussions on common problem which are there. Now, there are two issues are there. Obviously, there was snake bite, bite marks were there, and then subsequently tourniquet was there. There was, you're seeing a lot of edema, which is there. And once you took it off, the tourniquet, he had a florid sign symptoms of neurotoxicity. Having said so, dry bites will only be called if there are no clinical symptoms, one. Secondly, you talked in terms of coagulation abnormalities. They will only be considered, they will only be abnormal if you are seeing primarily viperine bite, whether it is a Russell viper, whether it is your saw scale viper, and now we are also seeing that the pit viper is also there in our country.
Yes,
so if they are there, then you will see not otherwise. Now, therefore, my question in this particular patient, I will not call it all a dry bite. Dry bite will be if I observe this patient in 24 to 48 hours and does not develop any symptom complex. In this patient, the question is, why was he having a breathing difficulty? And there's no tachycardia, there is no hypertension, no excessive sweating, which may say sometimes that adrenergic excess. Therefore, this patient has a clear-cut sign and symptoms of a neurotoxic snake envenomation. And secondly, because I have just been driving and be reaching home soon, I could hear the initial component. And if he's having a pain abdomen or pain anywhere else, we also need to rule out biotoxicity, which will not be surprised. Once you have removed the tourniquet, obviously the venom which was there got rapidly absorbed. And in spite of giving you 10 units of ASV, he developed the symptom and you need to give it more. Therefore, this is a clear-cut case of neurotoxic envenomation. The only question is it a crate or is it a cobra? Now, that is the only question. And the question has been further complicated because of the tourniquet application. If there was no tourniquet application with the local signs and neurotoxicity, it is for me cobra. If there are no local signs and neurotoxicity, it is crate. And if along with it, I find a coagulation abnormality, then it becomes for me the Russell viper.
Yes, sir. Thank you, sir. So now the second question is, as this patient initially didn't show any signs of clinical signs of envenomation before removing the tourniquet, and even the laboratory abnormalities was not there. So is it a right whether the indication for ASV is given? This question is to Dilip, sir.
This is a good evening to everybody. This is a clear-cut case of cobra bite. I agree with Dr. Dhruva. So as soon as tourniquet was relieved, a gush of venom has gone into the circulation. So this is a exactly proper time to give a ASV. But always remember that removing tourniquet should be applied properly first, and unless and until loading dose is given, it should not be removed also. There is a local swelling, clear-cut 2 marks, rapid deterioration, ventilation. All these are signs of the picture shows almost a neuroparalyzed patient and recovered completely. So this is the right time, 10 plus 10, 20 vials they have given, and I think exactly this is the right time, right dose, and patient recovered completely.
So what are the other indications for ASV, sir, in a snake bite?
So the indications of ASV, you can say local and systemic. Local, if the progressive edema, one thing, bites on digits, they are very, very dangerous, mainly palms and digits. Then regional lymphadenopathy, all these are local signs. And systemic neuroparalysis, cardiotoxicity, hypotension, shock, bradycardia, And hematological abnormalities like coagulation profile is disturbed, WBCT is incoagulable, clear-cut signs of consumption coagulopathy, that is VICC, systemic bleeding, all these are the signs of indications of ASV.
Thank you, sir.
Okay.
Sir, the second question to you itself, sir. As the tourniquet is removed, so the entire venom rushed into the blood circulation. So this raises a question: will all the venom injected by the snake will it circulate in the blood, sir?
This question is to me.
Yes, sir.
Oh yes. That depends. But many times when the that depot of the venom, as soon as the tourniquet is released, because the bite of cobra and rustle is a deeper bite, so definitely it will go into either lymphatic or blood.
So you mean to say that
cytotoxic action will be there. That is the necrotic action because of local cytotoxins.
Yes. So you mean to say that most of the snake venom injecting is like intramuscular injection? So it circulates in the lymphatics. So when
yes, sir. So cobra and crate, because their fangs are longer.
Yeah.
So the bite is intramuscular. Crate is subacute bite.
Okay.
That's why it's a slow poisoning.
Okay, sir.
Even saw-scale have some deeper bite. As the size of the snake also depends. Cobra and viper, larger size, deeper the bite.
Okay, sir. Thank you, sir. So the next question to Dr. Ganapathy, sir. So what are the major disadvantages performing 20 minutes whole blood time for the Indian Big Four snakes, especially saw-scaled viper and Russell's viper?
Yeah, actually, the 20 WBCT, usually what they say is it is positive for Russell's viper and saw-scaled viper in South Asian countries.
Yes, sir.
So immediately, usually they say within 30 minutes it becomes positive, and it is an excellent bedside test. But the disadvantage is the main thing is the test tube. Actually, the test tube what we use should be a fresh test tube, and any chemicals should not be used. Number one, and any decontamination, it will show a false negative result. So we have to be very careful of using the test tube. Otherwise, I think it is one of the best tests for the bedside in our rural area, because we all have a high-tech tertiary center, but at the rural area where they do not have any other facilities, it is one of the best tests to confirm whether it is a Russell's viper or saw-scaled viper. Same thing, the test tube has to be fresh and it should not be decontaminated.
So subsequent to this question, how frequent we have to do this, sir?
Usually, what they say is according to the WHO criteria, it has to be repeated once in 6 hours.
Okay.
And Senthil, and if you have any other disadvantage which you have to put forth, you can put forth so that everyone can learn that also.
So one is
experience. Any other disadvantages, what you think?
So another one is time consumption. It is a very good test, as you rightly pointed out. It is a very good bedside test where it can be done in even a remote, resource limited area. So this can be done, sir. As you rightly pointed out, the tube should be correct. The one important disadvantage, it takes more time, sir. 20 minutes we have to wait so that the toxicity spreads very fast. So if we are able to reduce the time, so it will be useful. And moreover, we are seeing few false negative tests with this 20 minutes hold time. Initial time, it comes as a negative. After 1 hour or 2 hours, when we repeat this, it becomes positive. Yeah. So that crucial golden hours has been missing. So that is a one important disadvantage which we come across in our clinical practice.
At the same time, as you said, once you have
yes,
another the indication like swelling and other things,
yes,
instead of waiting for the WBCT, I think we can go ahead with the anti-snake venom.
Okay, sir. So this is a question to Dr. Ganapathy, sir. So WHO has advised syndrome approach when the snake is not identified. So most of the people comes with the snake. Recently, we had a patient who brought 3 snakes from their field and told that I don't know which snake has bitten me. You identify, because they have an idea that they have to bring the snake. So if the snake is not identified, so we go with the syndromic approach. So Ganapati sir, can you elaborate on the syndromic approach, sir?
No, exactly regarding the syndromic approach, you know, we have got 2 types of snakes, that is elapid and vasculotoxic snake. So suppose if you examine the patient according to the system wise, if it involves the central nervous system, if the first if they have evidence of first frowning, ptosis and other things, you should go in for a elapid bite. Similarly, if WBCT is positive and if the patient gives evidence of vasculotoxic symptoms like hemorrhage, first symptom like epistaxis and bleeding from the gums, you should go in for vasculotoxic like mostly Russell's viper and saw-scaled viper.
So the WHO has divided this into 5 syndromes. So syndrome 1, so the patient has been bitten by a snake and presenting to the hospital with the bleeding manifestation, then it could be a viperidae group. It may be a Russell viper or it may be a saw-scaled viper. Syndrome 2, if the patient has been bitten in the sea and presents with acute kidney injury with myoglobinuria, then it may be a sea snake. Syndrome 3, same snake which has been bitten in the patient while sleeping, and the patient presents with a neurotoxicity like ptosis or difficulty in breathing as seen in this case, then it can be a cobra or crite, especially if the patient comes to the emergency room or the hospital in the early morning, it could be a crite rather than cobra. And if the patient is having all bleeding manifestation and the ASV is not sufficiently working, or still the patient having a coagulopathy after giving adequate amount of ASV, then it can be a pit viper. Or if the patient having bleeding manifestation along with neurological manifestation, the last syndrome can be a Russell's viper. So what is the ASV protocol for dosage? So this is to Dilip sir.
So the ASV protocol for cobra, once it is diagnosed as a just 4 or 10 vials of ASV within first hour, if required, give neostigmine, atropine, and if there is no improvement in first hour, give another 10 vials. So the 20 vials is the maximum dose for cobra bite, and if there is a recurrence of the neuroparalysis, you can pour 5 vials more at that time. Great, we pour 10 plus 10, 20. But for Russell, 10 vials stat, if there is no improvement or there is no stoppage of bleeding within hour, give 10 vials more, and then 5 vials 6 hourly as per the whole blood clotting time test. For EKIS carrying interest or saw-scaled viper, if it is brought, then 4 to 6 vials. And if it is a vasculotoxic snake not identified, then start loading dose of 10. So in nutshell, cobra is 20, crate is 20, viper is 30, and saw-scaled is 4 to 6 vials. This is as per the STG guidelines, but there is a definite regional variation to all these protocols. But this is as per standard treatment guidelines 20116 Indian guidelines 20, 20, 30, 4 to 6.
Sir, as per Indian snakebite national protocol, what they advise is for any neurotoxic, as you rightly pointed out, 20 vials or maximum 25 vials for cobra we can give. For a Russell's viper, maximum 30 vials. A saw-scaled viper, again it is 10 to 15 vials. Depends on the clinical situation.
But sir, observation is that nowadays
variations is everywhere.
Lethality of all these snakes is changing.
Yes, sir. Yes,
even saw-scaled viper has become more dangerous now.
Yes, sir. So what is the major advantage and the disadvantage of using polyvalent? This is a continuation of same question, sir.
Sir, basically we India produce a polyvalent because monovalent is not possible because India is a vast country and even in same species, the Russell viper of Tamil Nadu is more dangerous than Russell of Maharashtra. So there is a antigenicity variation, hence national antidote is not possible. And for polyvalent ASV, if a doctor is unable to diagnose a clear-cut snake, he can pour polyvalent, which will cover cobra, crate, Russell, and AKs. Disadvantage is that the chances of reactions are very high, and dose is given and the cost increases. But monovalent ASV, that will be pinpoint and which is not available in India. So that will give correct dose, minimum dose, and perfect. That will be the treatment. But in our country today, it is not possible. Polyvalent, so chances of contamination, chances of anaphylactic reactions, and lot many things. At root level, very few doctors they can identify a syndrome or they can go by syndromic approach. So these are the advantages, disadvantages.
Thank you, sir. So what are the disadvantages in developing monovalent antivenom? Dhruv, sir.
Sir, monovalent antivenom production is not possible in India because even it was not attempted also. That is because of a biodiversity, because I'm telling the Russell viper of Tamil Nadu, Russell viper of Maharashtra, and other states of India. Then cobra, even cobra intra-species variations are there in antigenicity.
Yes, sir.
So the monovalent, even then for answer for this is only a regional snake, anti-snake banks.
So you mean to say that geographically it is unique, so it will not be useful.
So it, because of geographic variations, biodiversity of snakes, it is very difficult to make a monovalent. So our demand is every state has a regional ASU banks. So that will be a perfect venom will be collected and perfect antivenom will be produced, and that will be a perfect dose.
So actually I did in Sri Lanka, sir, the toxicology course I did in Sri Lanka. Actually in Sri Lanka, the snake venom, which has been, they don't have their own production of ASV. So they are getting from India. So every batch we can see the difference. Suppose if the venom has been manufactured from the Bharat Serum companies, the batch is different. Every batch we see the difference. Some batch from north, the venom which is coming is not as effective as what we see in the south venom. So as rightly you pointed out, it is geographically variant, and so we have to construct on more on regional ASV bank. Thank you, sir.
Okay, because major venom is collected from Urula of Tamil Nadu.
Sir.
You see again, Dr. Senthil, what Dr. Dilip has said, you can use it only monovalent if you are able to diagnose.
Yes, sir.
If you are not able to diagnose, like clinical syndromes, if you really ask me in the north, everywhere things have been becoming different. You will be surprised that this year itself we have ventilated around about 55 or 56 patients. Yes, except one, all have gone up, and the person who could not go home was actually had a cardiac arrest outside. But having said so, there obviously we are looking at it's a neuroparalytic likely to be great because you have no peripheral signs. So we need to develop first testing which particular snake has bitten, A, and then what is causing envenomation, 2, and then obviously variability in the venom which is responsible. But by and large, when you are using dominantly, because all these are the next question you're putting up is again, they're all monoclonal antibodies. Obviously, what you're using is immunoglobulin G. And when you use it up, we need to have a data. Only then we can be in a position to say, like in Australia, it's all monovalent.
Yes, sir.
So depending upon that, mapping is required. You need to know the pattern of diseases is the pattern of bites are required.
Last, if you ask me in the 10 years, we have ventilated more than 600 cases. But you will be surprised, as a postgraduate in 80s, I used to see a lot of viperine bites. Hardly seen 3 or 4 over the last 5 to 6 years. What is the reason? I don't know. Maybe some amount that probably because of inhabitation or they have gone to a little farther away, though they're still reported from Punjab. Similarly, like you are seeing viperine bites from south, but suddenly it has dried up in my state. So that means we need to continue to have that. It's a dynamic situation which is happening, but I was looking at the data in my own state. Roughly in each district, 40 to 50 people are being ventilated. And if I have 20 districts, that means in the monsoon season, post-monsoon, that roughly you are having 800 to 1,000, but the government doesn't have a data. We don't have a data. Probably now the new ICMR study may be able to give us some amount of an idea how much is the incidence, because whatever you are talking today is all conjectural, being extrapolated from what came out in 2003, 2004 in PLOS ONE, which was published. So looking at it, still we do not know the extent of the disease, but we know each year our number is by and large static. That at my institution, which is more urban, semi-urban, rural, we have a mix of it, roughly around about 50 to 60, or maybe up to sometimes 70 are the patients which are being ventilated in each center. These are the ventilated. I'm not talking about renal failure, etc., which we used to see earlier. Of late, unfortunately, we are not seeing. Probably maybe change in behavior, or probably maybe viperines have been wiped away because of the change in the habitat, etc. I don't know.
Sir, in continuing of that question, sir, a few people in the rural area, the doctors are feeling bad, not giving ASV, delaying. They are worrying more about anaphylaxis. Does really this anaphylaxis occur because of this antivenom or any other reasons?
You see, any foreign protein you are going to inject. Sometimes people also with the preservatives may have it. Usually we had earlier the dry one, lyophilized, whether it is Hafkin or Kasoli. Now, whenever you're using their foreign protein, and now these reactions are markedly reduced since we have started using the change in the pattern which was there. With the lyophilized, we have seen much more anaphylaxis than with the liquid ones. And by and large, we again, whether the additional factor is responsible, I can't say straight away. But our by and large data is that out of incidences less than 10% with us. And we don't do any testing now anymore, whether it is in the eye or it is in the skin, ASV. What we are doing simply is that first half an hour, we give it very slowly, not more than rate of around about, we give it in the first, because 10 ml you dilute it and then you put it up, roughly 10 to 15 ml goes in the first half an hour. If patient does well, then we increase the speed and we try to finish it off in next 1 to 1.5 hours. But by and large, it is the foreign proteins, whether they are the anaphylactic, whether they are the antibodies which we are injecting themselves or the preservative, either of them, but dominantly Quine Sera, which we used to use early, is far more responsible.
Thank you. So
if there's something extra different viewpoint, most welcome.
Yes, sir.
Sir, I want to just, my opinion is that incidence of ASV reactions is very high. Even we are facing up to 50% of reactions. And majority are mild varieties, but 10 to 15% reactions are many times life-threatening also. Shock, bronchospasm, and lot many things. Now, if not contraindicated, we are using 0.25 cc adrenaline subcut prophylactic. We inject 0.25 cc subcut adrenaline, and then we start with ASV. Initially, as sir, he said that initial 10 to 15 minutes with slow, and then we give full dose. But this is not a dose dependent, this is a drug dependent. But a major cause, I will say that the mortality of snake bite in rural areas, why it is high, was a lot of doctors, they won't dare to give ASV because of a fear of reaction.
Yes, sir.
Unless and until they are boosted with treatment of reaction, prognosis will not change. And
I agree
point to
with you, Dr.
say
Dilip. We have
adrenaline will not be dangerous.
We have been using subcutaneous adrenaline as a prophylaxis, but by and large, of late, since we because in the government we have both supplies of a lyophilized and with the liquid one, and what we did notice was that with the liquid one, our incidence of reactions has come down, and it becomes far more challenging when the persons are on the ventilators. Then you realize suddenly if there is an urticaria, it is fair enough, unless until somebody has a lot of tachycardia and sudden hypotension and sweating, which starts into it. And they do settle with adrenaline and also with the shot of chlorpheniramine malate. I do agree with that.
Sir, what is your opinion about the efficacy of lyophilized and liquid ASV?
Sir, head-to-head trial, I have not done it. But what we found out was, because we are all brought up with the training with the lyophilized, we're quite happy with it. But by and large, except twice in 1 year when the batches were recalled, and we have got now the Hafkin as well as both B and Serum Institute, we have not found too much of a difference in it. But having said so, head-to-head trial we have not done. Therefore, everything will be hunching it, that I presume. But in an evidence-based era that we need to do. What I can share with you is in the neuroparalytic, we had got published that paper from PJ Chandigarh, late 90s, early 2000 to 2003, where we thought that what is the endpoint of giving anti-snake venom, where we used very high doses of anti-snake venom, thinking that stoppage and reversal is going to be there. But later on, what we have realized was that was a wrong approach, because it is only going to be effective with the free venom already, which is attached. That will, unless it lies itself has its own life, it won't recover. So basically, that has actually led to a significant reduction in the use of ASV with the no significant delay in the outcomes. That is point number one. Secondly, in 1 year, we did not have an ASV. And we saw that on an average, when we did not give ASV, but we kept the patients on ventilator, it took minimum again, that is the average time, was 3 weeks on an average when we were able to take up. That means there is a significant amount of free venom inside, though we have not been able to measure it, which continues to show activity, and muscle weakness, structural muscle weakness, other muscle weakness, they persist even up to 3 to 4 weeks. Therefore, ASV is mandatory to be used.
Yes,
as far as your hemostatic is concerned, because the bleeding stops, that's a very good endpoint. And then we have a lab good endpoint in terms of whether you do 20-minute test, PTA, PDT can take a little longer to settle down. So it is much easier to quantify the dose there. So here, what we follow is that if we give a shot, the progression, the march stops. So that is for us the key. And also even in the syndromic, where people come like a total brain death like syndromes, where they come up complete quadriparesis, like they have complete paralysis, where we have used ASV, they have recovered pretty well in 5 to 6 days. They take a little longer than otherwise. But again, it depends, variability. But those who have got a deep paralysis, which include internal and external extraocular, somehow they are lucky enough to reach. One sign which has been found consistently helpful, I hope you will agree, is that ask them to close your eyes. Somehow the frontalis muscle or the orbicularis oris continues to take. That is one way we have been able to say, okay, now the patient is okay, when you have an internal and external ocular muscle paralysis. So that's what our observation of last of more than 500 cases, what we have seen. And sometimes that's how you come and realize, because sisters say now they are expert in it at my center. But otherwise, earlier people used to say that we are ventilating a person who is a brain dead. When gradually
sir, we will discuss this in subsequent, sir, regarding this. Regarding the lipolyzed and liquid form, sir asked, just to add up to your point, lipolyzed has more shell life, sir, compared to liquid. So in a rural area where we can no need to have any refrigerator to store that in a lipolyzed form. If it is a liquid, we have to keep it in the refrigerator, otherwise this potential will lose. Another one important point, as Dhruv sir mentioned, lipolyzed, we see more amount of anaphylaxis. Actually, in Sri Lanka, we did a head-to-head compared trial between the liquid and the lipolyzed, because there we get only once we get a lipolyzed, the next batch will be liquid. So what we observed in our training period is whenever we dilute this, so this was not proper, sir. This is not true anaphylactic reactions. These are just a pyogenic reactions, probably because of contaminated thing what we use. So after observation this, what we started is we advise the staff to wash the hand clean and take dilute it in the proper way, and we load it, and we considerably noted that the anaphylaxis reaction has reduced much. So just like any other drugs what we give, the same precautionary method was been adopted. Then the anaphylactic reaction with the lipolyzed form was much reduced, and we didn't have the pyogenic reaction at all, sir. This for your kind information. So next is what are the major issues in using tourniquet following snake bite? This to Dr. Ganapathy, sir. You come across regular in your clinical practice. The rural area, they think that tourniquet is the lifesaver.
So the major issue of the tourniquet, we all know, because it can occlude the distal pulses, cause ischemia, nerve injury, and gangrene. So these are all the normal major issues. And sometimes they may go in for amputation also. At the same time, as you said, while removing the tourniquet, it has to be followed by the ASV. And we all know the snake bite, the venom is absorbed through the lymphatics. So a tight tourniquet is not at all necessary. These are the things which we normally follow, and we advise the patient also.
Thank you, sir. So this question is to Dr. Professor Thirumalai Subramaniam, sir. So the FFP in snake bite. So what is your advice, sir? Sir, you are not audible, sir. Sir? Some technical problem, sir is not.
Yeah.
So this question again to Ganapathy, sir. Can you elaborate on this?
FFP in snake bite, when and how much? So once if the patient going for coagulopathy, we advise FFP. As already told, along with the ASV, we give the FFP. Normally, we give 5 units of FFP statum, and we repeat to our experience, we repeat the WBCT once in 6 hours. And if it doesn't clot, we give FFP again. But once, though it is not given in WHO, instead of FFP, nowadays we prepare fresh blood so that it acts better than FFP in our experience along with the ASV, because it has got very good hemoglobin, so it takes of the oxygen, and it has got fresh clotting factors. This is our experience nowadays. So along with the anti-snake venom, with this dose, if you give along with fresh blood, the clotting also, the coagulopathy, we get resolved, the coagulopathy gets normal within 6 to 8 hours. You can share your experience also.
So the recent study says that we have to give FOP after completion of 20 vials over 12 hours or 16 hours. Before early starting of FOP is just adding fuel to fire for the consumable coagulopathy. So what is your experience, Dilip sir?
Sir, actually, I agree with you. Unless and until complete dose of ASV is not given, one should not FFP, one should not pour FFP. But if there is active bleeding, then there is a role of FFP. Generally, dose is 15 ml, 30 ml per kg. And then platelets, regarding platelets also, if the platelets are less than 30,000 and bleeding, then platelets are indicated. Otherwise, all this is a foreign material and there is every chance of reactions, trolley, that is transfusion related lung injuries. But those patients who have a few cases, even INR is not recordable. In such cases, FFP plus ASV does the magic role.
Thank you, sir. So, as those, I'll pause this. So, early morning paralysis and brain dead in snake bite. Dhruv, sir.
You see, my teaching to my residents is that early morning myasthenic syndrome is nothing else but snake bite.
Yeah.
And the reason is we learned the hard way. When I was a senior resident at PJ Chandigarh, we used to wonder these workers and the farmers and laborers coming early morning, what we dealing with, till the wisdom was given by one of the senior persons there. I'm talking of 91. And that is the day till today. We have not been failed by that observation and advised by our professor. So early morning, if somebody comes up with somebody has slept, quite often these patients may complain of pain abdomen, which they went and they sleep away. But this is not an uncommon thing. And roughly each year we see, if I am saying we are ventilating in our intensive care unit around 50-55 cases, so roughly 3 to 4 cases, they do come up with this. And if the residents on the duty, now fortunately our Department of Medicine, people are well aware about it since you have discussed a lot. So they don't mind intubating and sending them up. And quite often these people will be severely acidotic, both combined. And when you take them on ventilator, hydrate them and use them with anti-snake venom, usually they recover, though they take longer time. We did our data, we got it published also, the 192 cases in Indian Journal of Toxicology. There we found out that their recovery time is 2 to 3 times higher than the people who had not got it. So this is a known thing because you will have primary problem. It's like a complete neuromuscular blockage. And the challenge comes up more so with the crate because you don't have a local symptoms, especially on the dark skin, you can't see them. So we try to search for places. Quite often it has happened that I remember people going for an early morning ablution and then coming back, sleeping down, something bitting them there. And then in the morning they found completely frothy, and by the time they reached, they had nearly brain dead situation. Therefore, we need as a resident, as intensivists, and as emergency physicians, be aware about this condition.
Thank you, sir. So this question to Dr. Dilip, sir. What is the role of calcium gluconate in a crite bite, sir?
Sir, before that, I would like to add to Dr. Dhruva, sir.
Yes, sir. Please, sir.
Early morning, before that, I want to add one more thing. Activity at the time of bite and time of bite. Majority crate bite, they occur in midnight while sleeping and over about the morning and evening hours. And early morning paralysis with abdominal pain, that is nothing but crate with a neuroparalytic syndrome. That is 100% true, sir. Mainly in rural areas, the history is very important, patient sleeping on the ground. So the crate is a presynaptic blockade and cobra is a postsynaptic. Hence, cobra responds to neostigmine, and in crate, because of presynaptic blockade, there has to be a receptor regeneration, which takes a longer time. Hence, recovery takes a more time for crate bite. Calcium gluconate enhances the receptor regeneration and definitely reduces the stay ventilatory dependence, and recovery becomes fast. But still, crate takes a more time. So the calcium gluconate has a definite role. That enhances the receptor regeneration because in cobra, neostigmine that will release the receptors, but create new receptors has to be generated. Hence, it takes more time. Generally, 10 ml 6 hours till the reversal of neuroparalysis is recommended.
Thank you, sir. So complications of snake bites. It can be anything. So major complication, what we need to anticipate and what we need to counsel the patient's relative for this. Sir, Dr. Ganapathy, sir.
It's a very vast topic. So yes, first the complication, if you go in for neuroparalytic complication, and Dr. Dhruv told they go in for ventilator and you have to explain to the patients normally what I say is the earliest sign the patient going for impending respiratory failure is dosage. As Dr. Dhruv told, that sisters are very experienced. They can just see and they say whether the patient is going for ventilatory failure or not. And the second complication is coagulopathy. We all know about the coagulopathy, and now we have a heated discussion about how to treat this coagulopathy with anticyc venom, FFP, and fresh blood. And third one, and because if the coagulopathy is not corrected, suddenly they may go in for intracranial hemorrhage and all other things. So that is the other problem. And the third one is renal toxicity. So the renal toxicity, mostly it comes in Russell's viper bite and other complications like hypotension. So renal toxicity, they may go in for dialysis, and the patient will be asking whether it is a permanent renal failure, and we have to cope up with the patient. No, it is only temporary or till, and it is only acute tubular necrosis in their words. And if they become all right, then you can see them. Then the fourth one is importantly the necrosis. How are you going to combat with necrosis and treat the patient, and you go in for skin grafting. And the fifth one is again your question is that compartmental syndrome. Is it really insist? Because most of the patients they go in for rhabdomyolysis, they die. They go in for amputation, and it is because in the rural area it is very tough to deal with these patients, because they do not know the importance, why did they amputate, why rhabdomyolysis came, and even after our RRT and dialysis, after finishing, immediately because of immediately again they go in for hyperkalemia. These are all the tough complications we receive in this condition. And another one is important is this the capillary leak syndrome. Capillary leak syndrome is another complication, and in that complication, you have to tighter the IV fluids, whether to give fluids or you have to give more fluid or less fluid, when to give inotropic agent, will they go in for ARDS and pulmonary edema. So these are, and the complication is a very vast topic. So these types of complication we get, and we have to treat it accordingly.
Thank you, sir. So now, sir has pointed out about the renal failure. That is the most worrying about Russell's viper. So Russell's viper patients, when they present to it, this is another problem which we regularly face in the rural area. So when the patient comes with a snake bite, we treat with ASV, and after 48 hours, the patient may ultimately go for a renal failure where the dialysis is needed. Is there any prognostic marker? When we searched, when we found that there is a NGAL can be used. So what is your experience, sir? Dhruv, sir?
You see, NGAL, I have no experience because we are not using it at all. And
Okay.
By and large, as I said, most of the time the center where I had got trained at PJ Chandigarh, we used to discuss and talk, because initial series in terms of renal failure and everything has come up there. Now, NGAL is a marker to pick up early kidney injury, and you can use it in both blood and the urine, but I have no experience at all, so I am not in a position to talk about it.
Thank you, sir. So regularly we are using NGAL, sir, and we found that NGAL is very useful marker, bedside marker at the time. So once the bite patient comes, within 6 hours, if you see the NGAL, if the NGAL value is less than 250, then most of the time they don't go for acute kidney injury. If it is 250 to 450, they may go, some rise will be there. So we can avoid nephrotoxic drugs and other things. So preventing further damage. If it is in the more than 600, definitely this patient will ultimately land with renal replacement therapy. This is our observation. And we also published this paper in Toxin Journal. So the compartment syndrome, this is another important issue. So most of the Western literature, they say that we no need to do anything. Surgical intervention is not needed for snake bite because the compartment syndrome, the pressure is not exited. Actually, we did an 18 snake bite patient, we did an MRI of the limb. We found that there is no fascia at all. As Dilip sir told, because of the fang marks, this venom transfers in the lymphatics. So this lymphatics will destroy the fascia. So there is no tight compartment. So the real true compartment is not seen as of we seen in the Western world. So this is another important complication. This has not been much discussed or much reported. The cardiac complications. So Dr. Dilip sir, can you elaborate on this?
Yes, sir. We have experience of treating cardiac complications. Those patients who have bite on fingertips, where the bite becomes a direct intravascular. I have seen a patient who developed within 10 minutes ventricular fibrillation. I have seen infarction. There was a patient of Russell Viper bite who developed infarction, lot of coagulopathy, thrombolysis was out of question. I am placed at root level, remote part, higher center, primary is not possible. So this is a horrible situation. But what we could observe is, sir, acute myocardial infarction, shock, refractory shock, arrhythmias, bradyarrhythmias, tachyarrhythmias. These are the cardiac complications. But mainly, hence, definitely I suggest that the bites on digits should be taken very, very, very seriously. They are very dangerous bites. Even minor local necrosis will indicate that this is a venomous bite.
So Dhruv sir, your experience, sir? Cardiac complications?
They are there. In fact, we see autonomic complications, especially with the neuroparalytic. We are also seeing a cardiac complications, both in terms, as you said, we have and seen a couple of them, even like VF and sudden cardiac arrest, especially when tourniquets are opened up. So looking at it, when you have a myocarditis or you have other in crate and in cobra, it's not uncommon to have it because myotoxicity, these venoms also act on the muscles. So it is known, and quite often in these patients who are hypotensive, you may, beside third space sequestration, you may also find a significant myocardial depression. So there is no doubt about it. They are there percentage wise. We in our intensive care unit, when we were looking at it, around about 15% of the people have it roughly autonomic and cardiac muscle dysfunction. And as far as your if I talk in terms of the skeletal muscle injuries, practically it is universal. The only thing is we don't measure CPK very frequently. So looking at these are very well known complications. They occur and which we do it. One comment about the compartment syndrome. Obviously, and the gangrene, we have seen the patients coming up where practically whole of area gets necrosed. And the compartment syndrome, Dr. Senthil, commonly seen when you do an extreme fluid resuscitation. That is the time when the leaky compartment starts coming up, not otherwise. Because if you are, and another complication, which obviously you talked in terms of FNGAL, which have happened, is actually your renal ones. But as the question was specific to the cardiac, and we are seeing in around about 10 to 15% of the cases where they have challenges and issues. And in these cases, we also look at stroke volume variation, which was there. So as the patient recovers and you start giving it, these all are reversible and they come back.
Okay. So another important question is delayed complications of snake bite. The question why I am raising is most of the insurance companies, they still believe that after 48 hours, the venom half-life is over and nothing will happen. So the patient who is admitted should be discharged after 48 hours. That's how they have an idea.
So I think that is not
don't
true.
have an idea about delayed complication of snake bite. So what is your experience, sir?
You see, my experience is that especially with an intraventricular bleed or that somebody has intracranial, or one has seen Sheehan syndrome happening to these patients of long term, where they will have a pan-hypopituitarism. One has seen, one has observed, and one had followed up those cases and managed them. Second one is obviously a chronic kidney disease following snake envenomation. And again, remember one thing, those who develop kidney, again, I'm talking about from my experience with Dr. Kripal Singh Chuk at PJ Chandigarh, where large data has come up along with the Bangkok from the Mahidol University. There again, acute cortical necrosis. One has seen it. And if somebody is not going to pass the urine in the next 7 to 10 days, is for me, is the ringing bell that this patient is going to develop now CKD. I've seen 2 patients also who could not recover and underwent renal transplant. So therefore, these things are known and sometimes subclinical. When you have not given adequate, you can continue to see the abnormality of a coagulogram and a low doses and a low platelet count, which you can say a low grade DIC, if I can use the term, continuing for 6 to 8 weeks.
Ganapati sir, your experience on delayed complications on snake bite, sir. Sir, you are in mute, sir, please.
Yeah, delayed complications, actually, as you said, not only the insurance people, when I went to a couple of conferences, they used to say, usually they admit snake bite, all the snake bite they admit and they keep it for 3 to 4 days because they do not know the importance of the complications of most of the doctors and even consultants. And even on the forensic medicine side also, they told simply all snake bite, these doctors admit they keep it for 2-3 days. So for me, mostly the delayed complications, in my experience from, I have seen 3 or 4 cases of cortical necrosis, where they have to go in for, which was very rare. They went in for renal transplantation. From 1986, I am practicing. Around 4 or 5 cases, they have gone in for cortical necrosis. That is the one. And Sheehan syndrome. And they also go in for hypothyroidism. Some patients, but because as I am in the rural side, I am not able to investigate, and I do not have any postgraduates also. So they go in for hypothyroidism, and even some patients probably because of the involvement of the pituitary, I'm not sure, they are on thyroxine. So only these types of complications I have gone.
Dilip sir,
I want to add a few things that I agree with that. We have even published a case of empty cellular syndrome, which is causing pan-hypopituitarism, hypothyroidism. We have observed hypertension after crate bite. Why? But I can't explain. Second, more commonly observed complications.
Sir, you are not audible, sir. Can you repeat, sir?
We have observed. Am I audible, sir? Now?
Yes, sir. Please, sir.
We have observed hypertension after crate bite. One thing. Second, we have published a case of empty cellular syndrome, which is causing pan-hypopituitarism, even hypothyroidism. One more complication after Russell viper bite is the persistence of swelling for a longer time. That viper is a high molecular weight. That's venom, and it acts like a filaria. So patient may have a longer time swelling. So then a lot of complications regarding contractures, gangrene, disability. All these are the delayed complications. But swelling, and one more thing which is always neglected in snake bite is lot of patients, they get a mental trauma. There are social complications also in our area. Those girls who are bitten by snakes, there are a lot of problems in their marriages. We do a lot of counseling also.
Okay, sir. Sir, regarding capillary leak syndrome, what is your experience, sir, and how you manage it?
Capillary leak. So the capillary leak syndrome is basically because of endovascular damage. Main stain is anti-snake venom, inotropes, steroids. Other drugs, they are drug disease modifying agents and plasmapheresis. I am at root level, they are not possible. But capillary leak syndrome has a worst prognosis. Those who respond to anti-snake venom and inotropes, they will come out with AKI, dialysis, and lot many things. But refractory shock has a bad prognosis, and capillary leak syndrome is a main problem of South India.
Yes, sir.
It is a South Indian problem. It is not that much worse in our state, but almost 85 to 90% mortality is there.
Ganapati sir, your opinion, sir?
So yeah, capillary leak syndrome, usually what they say is it occurs mostly in Russell's viper. Russell viper is the main culprit, and normally the diagnostic criteria when the patient has got persistent hypotension, when the systolic pressure is less than 90, hemoconcentration more than 45. If the patient has got proteinuria, and if the albumin is less than 3 grams per liter, and sonographic wise, ultrasound, you can see fluid in the third space. So these are all the main things. And clinically, normally the patient, they come with chemosis, swelling of the parotid gland, and what they say is a viper head. The patient mimics like a viper head. That's what it came in Critical Care Medicine Journal. And as I already told you, the management is an art because this viper bite protein affects the capillary endothelium. And also the cytokines are released. So because of endothelial damage, there is leak of protein. And as I already told you, it is very difficult to manage whether to give fluid for the patient or to restrict fluid or to give albumin or to give inotropic agent, or in a hemodynamically unstable patient, whether they should go in for CRRT. So it requires a very high-tech intensive care where we can save them. Of course, the mortality rate is very high.
Thank you, sir. This is a question to you only, sir. Ganapati, sir. The pregnancy and snake bite, what is your experience, sir?
So pregnancy and snake bite, as already told, the same amount of anti-snake venom has to be given. And even for lactating muscles, mother, it can be given. And you have to see for fetal hypoxia. But we have received, in my experience, 4 or 5 cases of pregnant women in the past 20 years because it is a rural area, and we are able to save them. There was no mortality. And regularly by ultrasound guidance, we see capillary leaks, and also the fetal heart rate and viability of the fetus. In any other points anyone can discuss regarding pregnancy and
So we have experience of almost in last 35 years, we have treated almost 35 to 40 pregnant ladies having neurotoxic and vasculotoxic bites. I agree with Dr. Ganapati sir that the protocol is same, dose is same. Only thing is that till the recovery fetal monitoring is must. We have observed patients from first trimester to till the delivery. Literature says 40% fetal and 10% maternal loss, but even at our remote rural part, we have not lost a single mother or fetus. All of them are doing well. Only thing is that for 2 to 3 days, fetal distress has to be observed, or bleeding PV in hemotoxic bite, abortions.
You see, neuroparalytic, in continuation of what Dr. Ganapati and Dr. Dilip said, neuroparalytic, like we have treated around 3 to 4 cases, we had found no issues. Challenges are much more when you have a DIC. That is the time when it can land up. And the question also is whether the placenta, the snake venom crosses the placenta. Though some data says it does, but still we don't know. Nevertheless, as Dr. Dilip has said it, chances of antepartal hemorrhage, you need to be careful, because especially when you are having a Russell or other bites. As far as the crate is concerned, it's a neuroparalytic, and same is true also for cobra. So you will manage the rest of the patient like this, but there should be a very close fetal monitoring, which is going to be there in this case. And be very, very careful in cases where you have clotting disorders, in fact, in biprine bites. Our experience, which is limited one in terms of pregnancy, 3 to 4 cases, they all have done well.
Sir, today we had a very wonderful discussion on snake bite. This is a real eye opener. So this is a high time that our ISCCM should come with a question paper on snake bite management. And before completing, this is one repeated question asked by all the participants. What is the role of forced alkaline diuresis in snake bite? Dilip sir?
Sir, forced alkaline diuresis has a variable results at variable centers, but the people from Northeast, they say that it shows a good, excellent result. FAD helps in oliviric phase only. Once patient becomes anuric, it is useless. Then
Yes.
renal replacement therapy is the answer. So the 40 milligram stat Lasix, then normal saline 500 plus 20 ml soda bicarb in 20 minutes. Ringer lactate plus 20 ml soda bicarb in 20 minutes. 5% dextrose plus 10 ml casol in 90 minutes. And mannitol 150 ml in further 20 minutes. So the total time is 150 minutes, 2.5 hours. Total fluid given is 1700 ml, and output expected is 3 ml per minute. We have few cases patient responded, but it has to be started in initial oliguric phase only. Once patient develops ATN, acute tubular necrosis, then the creatinine goes on increasing.
Yes.
But
You see, it's Dr. Senthil, primarily, in the modern management, I don't see any place for it. Because the only thing which is needed and required is early identification and anti-snake bite. That is what is required, what is needed at any point of time. Basically, it leads to rhabdomyolysis, and that is where you can feel that FAD may be beneficial so that it doesn't block the tubules. But again, quite often, it is inadequate hydration, which is the key, and inadequate use of ASV, which is the same thing I'm talking about. You did talk about earlier was of the calcium gluconate, because people did say that let's give and try it in patients of great. And trust me, it all depends end of the day on the availability of the ASV, where you are. So I look at it like this. If it is there, I will rather take up this patient today on treat with an anti-snake venom and take them on dialysis and renal support.
Okay, sir. Thank you, sir. Prashant?
Thank you. Thank you so much, Dr. Senthil, for taking us through this journey.
Question which is there, I think we need to talk about, which are as important, is there a life-threatening anaphylactic reaction to ASV? So should we still give ASV after controlling anaphylaxis? Because this is something I learned my snake bite management with the case. I can never forget it, and you can learn from my mistake, which I did it, is that a young lady came, had a local symptoms, and was shouting a lot. And I'm talking of 91, a young senior resident passing MD medicine. We gave anti-snake venom, and I've never seen such a florid anaphylaxis, where patient had left bundle branch block, full-blown myocarditis, pulmonary edema, and later on developing and had to be on cardiac support. Therefore, when you use anti-snake venom, be careful. That person must have clinical symptoms and clinical signs along with it. With the signs, with symptoms, signs are there. If my panelists disagree with me, please let me know. And we will be more than happy about it. And secondly, once you give it, keep a very, very close watch. And third thing, which we have started, as Dr. Ganpati has said it, and Dr. Dilip also, that we are nowadays using prophylactic 0.25 ml of subcut adrenaline before we start it. And third is that a patient, if has continuous bleeding or continuous coagulopathy, or has an ongoing evidence of clinical evidence of envenomation, you can give anti-snake venom under adrenaline drip and a care. The only thing you need to be careful is adrenaline itself has a significant side effects. That part you take care. So what we practice at Rohtak is, we start them in 1:50,000 dilution, and then slowly give it up, and we prime it for half an hour. And after that, we restart ASV, but the speed is much slower. And this is what we are. The challenge comes up when person develops acute renal failure, because fluid loading becomes a problem. And third thing which I need to tell here is, my panelists, I hope, will agree with me. Whatever your age, whatever your size, there is no alteration is dose of anti-snake venom. Because you are treating you are treating venom, and you are trying to take away the effect. Even in a pediatric age group, you will use the same amount of dose as you are using in the adult. So if there is any difference with it, please express your viewpoints.
Sir, I agree with you, sir. The dose in pediatric and adults is same. Even juvenile snakes should not be taken lightly. Juvenile. Hello.
Yes, sir.
Juvenile snakes should be taken very seriously. Even they are equally lethal to adult snakes.
Actually, more toxic. Juvenile snakes are more toxic than the adult snake.
Oh,
And
definitely.
another important thing is size of snake has nothing to do with envenomation.
Newborns of snakes are more dangerous than adult snakes.
Even envenomous snake can have a dry bite if it has a feed before that. Therefore, I think a lot of factors is there. The only thing is, if ask me what not to do is never go by the Bollywood, Tollywood or Rollywood anywhere to suck the things from there.
Definitely, definitely.
Secondly,
Treatment should not be more dangerous than the bite.
What is the Australian approach we tend to advise? That you use a crepe bandage, likely you find it, and obviously you stabilize the joints like you do for the fractures, so that one joint above joint. So with the movement, as has been very elegantly explained by Dr. Dilip, Dr. Senthil, and Dr. Ganpati, that it is absorbed through lymphatics. So stop that. Don't cause ischemic gangrene. One has seen people getting amputations because of tourniquet rather than anything else. And I think we need to spread the message that it's a treatable emergency. You come to hospital in time, everybody should go home walking rather than anywhere else.
Absolutely right, sir, and very well said. Thank you so much, all the panelists, for the information shared. And I would like to thank Dr. Rajesh Mishra, President ISCCM, for taking this initiative of Toxicology Network and making this day happen. So I'll request Dr. Mishra to say a few words for this.
Rajesh is here. I saw Rajesh. I think.
Yeah, he's here. Sir, you are muted, Dr. Mishra, sir.
Good evening, Dr. Ray.
Yeah, hey, good evening, group. It was terrific session, I must say. I think. Rajesh.
Sir, I heard you up to 8 o'clock, and then I had a different other meeting to join.
Right.
The internet that I had to join. But
Hey,
definitely,
just spend a few seconds to give a message, Rajesh.
Yeah, sir. So I think the first discussion was terrific. Few new things I also learned, and I think it will be great initiative. So whatever we are doing to, spread the knowledge and spread about toxicology, because this is one area where we have maximum problem, and we have probably worked very less. So whole 1 year, your team, Dr. Rungta's team is working so hard, whole team is doing so much. And I believe that we are going to come out with a lot of things which people will learn. So nice, sir. Thank you for doing this. Keep on doing. My full support is there with the team. Whatever you want, everything is yes from my side. So please go ahead and do the best, whatever can be done in toxicology.
Thank you, Rajesh. I think it has been a tremendous session, I must really say.
Yeah.
Dr. Rungta, if he is still hooked on, your stewardship has actually started with a bang, I must say. I think I would like to profusely thank Senthil, Dr. Dhruv, Dr. Dilip, and of course our Dr. Ganpati. I think these three, and with the moderation of Dr. Senthil, they have taken everything out of it. I was just going through the questions. I don't think any question has remained unanswered, right? I think all the questions have been answered. If there is any, I am sure, I think they can always find the answers in the deliberations. So therefore, I think thank you very much, all of you, all four of you. Then Prashant, I think your coordination has been excellent. And of course, Dr. Rungta, your stewardship has been terrific. So Rajesh, your thought has given results, I think, with a bang, and it is going to continue for I don't know how many months and years. I think it is going to be a continuous process. Thank you all, audience, very much for listening to a fabulous feast of information. So with this, I take leave of yours, and I think good night, all of you.
Thanks.
Thank you all.
Thank you, panelists, and Senthil, you were excellent. Even I learned quite a few things.
Thank you, sir.
We have never used it, but it was thank you so much.
Thank you, sir.
Thank you now. Yeah, yeah.
Thank you, everybody.
Thank you, Dr. Ganpati, sir.
Yeah, thank
Always
you.
a pleasure.
Yeah, bye.
Yeah, thank you, Dr. Dhruv,
Thank you.
Dilip, and everybody.
Oh, thank you, Anand.
Yes, thanks to
Thanks a lot. Thanks a lot.
everybody. Yes, nice to see you all.
Yeah,
Oh,
same
it
here.
was